Hello everyone, my name is Christy Gable and I am the perinatal clinical nurse specialist at Sutter Roseville for Women's and Children's. I am here to discuss the new quality and, I should say new and newly revised quality improvement and safety project for Sutter Health on safe sleep for the prevention of sudden unexpected postnatal collapse and prevention of newborn falls. It is November of 2021. Next up, I will be talking about the situation of why we chose to do this project. Every year, approximately 3,600 infants in the United States die of sudden unexpected infant death, or SUID. This includes sudden infant death syndrome, or SIDS, sudden unexpected postnatal collapse, or SUPC, unknown and undetermined causes, and any accidental suffocation and strangulation in an unsafe sleep environment. SUPC of the newborn is a rare and serious event that occurs within the first week of life, but more likely within the first few hours of life. So the PEDS and NICU Clinical Improvement Committee has been working collaboratively on Sutter's Safe Sleep Initiative to revise the current policies into one Sutter Health policy, revise and create patient teaching materials, and provide documentation for the nursing staff for assessment and education of safe sleep practices. Standardized policies for infant sleep safety, education for both staff and families, visible educational prompts, modeling of safe sleep, and audits for quality improvement are all elements of Sutter Health's Infant Safe Sleep Initiative. Next up is some background information. So what is sudden unexpected postnatal collapse? It is a condition in which a previously vigorous, spontaneously breathing infant greater than 37 weeks who had a 5-minute APGAR of 8 or more unexpectedly becomes apneic, often necessitating a full resuscitation. 1/3 of SUPC events occur within the first 2 hours of life. 1/3 will occur during the postpartum period, and 1/3 will occur within the first 7 days of birth. The incidence of SUPC in the first 2 hours of life is between 1.6 to 5 cases per 100,000 live births, but is highly likely that it's higher than that due to near misses that are often not reported. Characteristics include apnea, limpness, bradycardia, cyanosis, collapse, and cardiac or respiratory failure, or a blue baby. The most common cause is positional obstruction of a newborn's airway during skin-to-skin. And the United States is working to establish standards, protocols, and develop education for SUPC in hospitals across the country. Next, here's a list of risk factors. These are the most common ones that have been identified in the literature. So primiparity, fatigue that's usually due to long labors and lack of good sleep during pregnancy, especially during the later part of the pregnancy. Any narcotic use, administration of magnesium sulfate for preeclampsia, any distraction either with the television or use of cell phones and texting while the baby is skin to skin or attempting the first breastfeeding. And the first breastfeeding is also a risk factor. The prone position of the newborn, unsupervision during that first hour of life when the patient is attempting skin to skin or breastfeeding, the mother being supine with the head of the bed flat for her, and developmental risk, newborn that will not pull away if the airway is occluded. An additional large breasts or soft tissue initially once before her milk has come in, and then bed sharing is another risk factor. These are the components of skin to skin. The face can be seen, the head is in the sniffing position, the nose and mouth are uncovered, the head is to one side, the neck is straight and not bent, the body is facing the parent, and the baby's legs are flexed. Next up is the assessment for each area. In labor and delivery, we're going to provide routine care during that immediate postpartum period. So once the infant is delivered, we're going to dry and stimulate and place skin to skin if possible. You can also perform this in the operating room. Performing assessments and resuscitation as appropriate. Assist and support breastfeeding. This is done for the first hour of life to remain at the bedside, assisting with correct positioning and providing the introduction to the safe sleep practices education. The labor and delivery nurse or the NRP nurse will also perform skin-to-skin safety assessment and document these findings in the medical record. And we will be discussing documentation later in this presentation. You can also refer to the parent education teaching points that will be as an attachment in the policy, and it can be printed and also given to the parents if desired. During the postpartum stay, we have providing rooming in for 24 hours per day unless a medical reason is needed to separate the newborn from the mother and family. Perform all cares at the bedside if possible, so any heel sticks, assessments, hearing screens, etc. if possible. All newborns that are greater than 35 weeks should be placed on a flat surface on their back for sleep. The crib should be free of any extra stuff like bumper pads, toys, and blankets. We are encouraging the use of the sleep sack or safe swaddling. We want to increase our surveillance, especially for those at higher risk for SUPC or sudden unexpected postnatal collapse, as was previously discussed on the risk factor slide. If the infant is sleepy, place the newborn in crib or give to a family member who is awake and alert. We need to reinforce parent education, establishing education for feeding cues, correct positioning, watching the newborn during feedings, being able to see the face, color, what is in the crib, and then placing supine for sleep. We also want to model the behaviors for parents by placing the infant supine in the crib, use of the sleep sack or swaddling, nothing in the crib that's extra, and we're not tilting up the bassinet. We are also assessing skin to skin after the first 2 hours of life and completing the documentation in the medical record during vital signs, when the newborn is skin to skin, or during a breast or chest feeding. Document appropriately using the new flowsheet rows that we will discuss later and will be live in the electronic medical record on December 16th. So if the newborn is in the NICU or PICU or in pediatrics, we're going to help with skin to skin by helping with positioning and maintenance of that neutral head position. We're going to make sure that the parents or patient's mother is awake and alert. We're going to provide that safe sleep education, and we're going to document in the appropriate medical record flowsheet rows, which will be discussed later. Some of the alternative positions that are only used in the NICU, PICU, or pediatrics because of medical reasons would be side lying or prone. And we need to make sure that we are educating the parents that these are positions that are only to be used for medical reasons here in the hospital and not to be used once the baby has transitioned to safe sleep practices. Use of developmental devices to maintain that flexed midline position are things like the bunting, snuggle up, bendy bumpers, and prone positioners that we use for those babies that need to be prone. Once they've determined that the baby is able to transition to that safe sleep, it's usually a preterm that's moved to supine position at about 32 weeks gestation, no later than 35 weeks postmenstrual age or PMA. Safe sleep when stable at 32 to 35 weeks. Next up are the recommendations. In addition to what was just previously discussed during the assessment phase, there is documentation coming that will be go live December 16th. And these are the components. So there's two different groups for documentation. The sudden unexpected documentation is in the skin-to-skin safety group, and the safe sleep documentation is in the safe sleep WDL group. This documentation again will be live in the medical record beginning December 16th. So for the SUPC, or sudden unexpected postnatal collapse documentation, this is done in the skin-to-skin safety group. The WDLs are listed here as that the holder must be alert and awake, they're non-distracted, the head of the bed is elevated to 35 to 80 degrees, and this is the mother's head of the bed. The nares are visible, pink, and positioned. The tone is appropriate. The newborn's respirations are without grunting, flaring, or retracting. The newborn is awake, crying, alert, or sleeping, and the head and neck are aligned. If there are any abnormal findings or not WDL, these are the two rows that you will have access to document your findings. So the color, pallor, cyanotic, dusky, any grunting or flaring, retractions, tachypnea, non-responsiveness, and flaccidness. Any actions that you take, you also document here. So continue skin to skin, resuscitation started, and any education provided or reinforced. The SUPC, or sudden unexpected postnatal collapse documentation, can be found in the following flow sheets: the well baby admission, the infant vital sign, and the newborn daily. The well baby admission flow sheet is replacing the DEL sum. This will be the new flow sheet coming. Here are the safe sleep documentation components. So for WDL, you find the infant or newborn alone on their back, in a crib, or in an open incubator. There are no hats. Yes, I said that right. No hats. So once the infant or newborn is stabilized temperature, the hats can be removed and not in the crib. No extra pillows, any toys, or any extra blankets. The head of the bed is flat. That is for the newborn's crib. The head of the bed is flat. The newborn is in a sleep sack or safely swaddled. They can also be skin to skin or held by an awake, alert adult. Safe sleep education is provided, and any practices that apply to a medically stable infant who is 32 to 35 weeks postmenstrual age, or no later than when the infant is transitioned to an on-demand or ad-lib feeding plan. Any findings or interventions that you provide, the preterm infant does not meet these criteria. There are items in the crib. The infant is not in the crib. The head of the bed is elevated. There are positioning aids in use. Not supine. The newborn, not supine. The newborn is being held by a drowsy or sleepy adult. And what you want to do is correct any of these findings to ensure a safe sleep, and again, reinforce those safe sleep practices with the parents. And here is what the Safe Sleep WDL group looks like. This can be found in the following: the newborn daily, the NICU care summary, and the PEDS daily care flow sheets. These are the new crib cards that are available in English and Spanish with information on safe sleep. This example is one without space on the front for footprints. Some affiliates will be using these same crib cards with space on the front for the footprints, with the alone on the back and in the crib information printed on the back. You can give this crib card to the parents when they're discharged. These are the things that we have included in the toolkit that was already disseminated, along with the components of the policy which I just shared. We have Safe Swaddling, a parent education sheet, which is an alternative to sleep sacks. We also have a parent education teaching point sheet for use with the nurse and making sure that all of the components are taught to the parents. We also have a parent brochure in English and Spanish. We have the new crib cards, as I just discussed, and the safe sleep practices that are listed in the policy, which I've already discussed with you. So if a parent chooses not to use the sleep sack, then we have these step-by-step instructions on safe swaddling. You can review this with the parents and do a demonstration with a blanket and have them practice with you. The second attachment is a parent education teaching point sheet that you can review and provide this specific education with the parents. This information is based on the American Academy of Pediatrics Safe Sleep Guidelines. This third document is the handout on pink and positioned with translation to Spanish on the back of it. So lastly, when are you to educate and document? Safe sleep initiation will be done with each transfer of care upon admission and reinforced with each parent encounter. Safe sleep findings and interventions should be assessed and documented every shift. Skin-to-skin safety assessment when observing skin-to-skin with either holding or with breastfeeding. And we want to make sure that you are reinforcing all education every shift. Documentation is done in the newborn's chart once the newborn care plan has been initiated. You can find it in the education under awareness of safety measures, safe sleep position / environment. So for your safety measures documentation, including here with the care plan, once the education has been selected, this box will appear. So you will complete all the green check marks and file it. For each shift, document each time the education is started and any time the education is reinforced. You can select the item again and click the document button at the bottom right and complete the same information in the pop-up box as in the previous slide. So that concludes this short presentation on our Safe Sleep Initiative for Sutter Health. If you have any questions, please contact your unit leadership team. And again, thank you for your time today and listening to this recording.